What am I doing here with this picture in the sand? Once upon a time, somebody invited me to Kuantan in Malaysia. The Sheraton Hotel was right at the beach, and that's where we had the course. In the morning, I went out to the beach and I saw this Persian rug. Can you imagine? This is the beach. Before, of course, the tourists destroyed this artwork of nature. What are you talking about? Crazy radiologists with a camera in hand. What is your only thought? That there are zillions of radial scars here. How come? Here is the little guilty guy. Do you see this sand crab? And this is what he produces by taking out the food from the sand. There is a high tide and a low tide, and when the water goes back in the morning, leaving a smorgasbord for the little crab, he comes out because he was sleeping down in the hole and does the following. Look at this video. You see the little crab here? Chewing through, takes out the goodies from the sand and throws away a ball. And then takes other pieces, planktons and debris and dead whatnot, eating breakfast, and then throws the bowl away. I understand that. He has to survive. That's fine. But how come that he produces this pattern? Please read this. Once upon a time, 1735, the Swedish famous botanist Carl von Linné called it Cancer emeritus. It's a mole crab that burrows a hole in the swash, that is the white part of the water after incoming wave was broken, and filters plankton detritus to survive. And then he produces these equal-sized balls and makes this pattern. Why? Because he believes that there is an enemy around, and so he uses these as a wall. So this is an escape corridor. When the enemy comes, then he runs into the hole. Poor him. He doesn't understand that the enemy comes on wings. It's birds coming from above, and while he is eating breakfast, he becomes a breakfast for the birds. C'est la vie. So these serves as walls of labyrinth, of protective escape corridors, so he can retreat to the safety of their hole should any danger threaten them. Did I've seen this somewhere? And that was in my 3D microscope. It's very much similar. Well, here is a hole, but here is a fiber elastic cord. That's fine. Enjoy, please. Why do I spend so much time on this? I hope that this kind of a teaching trick makes the radial scar stick to your mind. Can it be solitary? Look here. Many sand crabs, many radial scars. Practically every mastectomy specimen, the pathologist finds a lot of hyperplastic breast changes. Most of the times it's fibrocystic change. Sometimes it's a papilloma. Many times it's PASH. Many times it's radial scar. But you see, they don't spend too much time on describing these because that's not a cancer. Cancer is the most important thing, sure. Look how many radial scars in a fraction of a mastectomy specimen, plus fibrocystic change, ductactasia, and so on. Isn't that nice? Beautiful. Breakfast feast in Kuantan, Malaysia. I'm showing this because now a lot of cases are coming. And I'd like to remind you by showing Vasarali's tapestry that a good radiologist focuses on the black in order to see the white. Let's do it. Here's a microfocus magnification on the CC projection. You found architectural distortion. And now you analyze the extent of the radiating structure, no central telomeres. And then you analyze the radiating structure. And with a little fantasy, you say, this could be a black star. And what is radiopaque? Well, the periductal elastic tissue. This is not like in the BCMO, the spider's web skinny lines. No. These are proliferating duct. Well, it could be the benign, or it could be the malignant DAB as well. What is important is that it changes its appearance from projection to projection. This is amylo, this is a lateral medial horizontal. That was the CC projection. These are all tricks of the trade. We are building up the diagnosis. One idea, another idea, and you arrive at a diagnosis. Series of radial scars for practice and trying to differentiate from AAB, stellate invasive carcinoma. Clean your glasses. It's going to be difficult to find. Here it is. But when you find it, you say, well, this is thick and it's long, so it's drooping. Here it is. The radiating structure is this big. I don't see any black star here, but I think this is some kind of a DAB, benign or malignant. Where is it? It's there. Could you magnify this? Yes. Take it out generously again, and then this is one of the few cases where there is so-called carcinoma associated with radial scar. But I told you, it's not grade 3. I'm going to show you quite many photographs from Sao Paulo. Once I was there and colleagues were very kind to take me to a botanical garden and museums and so on. This is always true, whether it's benign or malignant, that we should make the precise correlation between imaging methods as well as large format 3D pathology, thick section and thin section. But in these cases, the thick section is fantastic. This is what the breast cancer looks like. Multiple radial scars, fibrocystic change. What a difference, So now you have this radiating structure in front of you. Asking about trauma? None. Palpable? None. But I can be fooled because there is such a tremendous cushion here. But this is large. Could you give me the mag? Yes. So, now I fantasize a little bit about a small fibroelastic core and these fingers, which means distended ducts. It would be great to see the histology in 3D. Be my guest. Here it is. This one corresponds to this. And these correspond to the distended ducts. Here you go. Some of them are cystically dilated. The radiating structure is much, much bigger than the central fibroelastic core. And we are going to learn about the apocrine metaplasia that produces the fluid and makes the cystic cavities. There is no associated cell proliferation atypia cancer in this particular case. Simple radial scar. Now this is a simple radial scar. However, it's so huge, the patient refused surgery. I got it from Brisbane from Dr. Cheryl Hurst. One of the largest radial scar I've ever seen. Fills the whole half breast, the upper part. And dear colleagues, this is how you analyze it. This is black star. The radial scar must be examined with large section, and then you can use different staining methods. If you use the elastic staining, then you are going to see those proliferations I was talking about, sclerosing ductal hyperplasia. Work with me. Young woman, she is 30-some, You look at the black in order to see the white. What pops into your eyes? This one. This is harmony. This is disharmony. We are going to magnify, and it's here. Make up your mind. You got 3 seconds. Black star or white star? I would start by going for the extent of the radiating structure. In addition, this is black, radiating lucency. And this is a disproportionately small central fibroelastic core. Here you got the histologic proof. And of course, it cannot be fun for the surgeon to remove a whole quadrant just to prove that this is a benign process. But don't blame the radiologist. I haven't produced this. I just found it. And it could have been cancer associated with it. Where is it? It's in the medial half. There in the left breast. Radial scar. This was great. I was taken to this wonderful museum. I was in the upper floor. Here is the teacher lady and teaches the kids about art. And Latin people are just admirable, artistic. But I thought that was kind of a radiating structure, wasn't it? Where is it? Here is the skin. She did not have trauma. And you palpate. Your finger is right here. And this is huge architectural distortion. And it's not palpable. Then I say, first of all, it cannot be BCMO. It would be palpable. And it does not have these thick duct-like structures. Could this be a DAB? Well, if I say it's not palpable, although it's right here, let me not think about cancer. I feel empathy with women. Can I make this look like a duct proliferation, but the benign type? Radial scar? Where are the proliferations on this side? How come it's only on this side? There is no cancer like this, you know what I mean, that leaves half of the circumferential area without speculations. No. This is going to be a radial scar, and histologically proven radial scar. Very quick test for you, which one is white and which one is black. You see, even if this cancer is smaller than a centimeter, the surgeon feels it, the patient feels it, you feel it. Even if it's 3 centimeters, nobody can feel it. And look at how black it is. You see, we radiologists are imaging the underlying histology. If the underlying histology is different, in this case radial scar, in this case cancer, of course the mammogram is going to be different. That's what I'm trying to tell you. A 25-year-old mother died from breast cancer, age 44. Grandmother died from breast cancer. Now she felt a little lump up here. And then she tries to tone down that it starts to regress. Don't ever believe a fairy tale like that. Neither hyperplastic breast change nor cancer will ever regress. This, what I show you, is quite a challenge for you. And I'm so thankful that she put her finger here. What is there? Well, that's what she felt. How interesting. Let's work on it. Where is it? It gotta be here somewhere. Is this one? But you never let it go away. She's 25. Architectural distortion. What palpable architectural distortion? I just refuse to think about my own rule. Palpable architectural distortion is either cancer or cancer. But she has this absolutely not spoiled face, 25-year-old. I have to squeeze out something. something benign. Dear colleagues, watch this very carefully. This is a proliferating duct. This is a proliferating duct. Does this look like cancer? Not for my eyes. Yes, the good ultrasound has great signs of a radial scar. You say, give me Doppler. And this one makes you happy, this one makes you less happy. It doesn't matter, I'm on it. And there is light at the end of the tunnel. Could be a radial scar. In this case, we just have to do this. And that says hyperplastic breath change. That's not good enough. The cancer might be outside here. Is that why it's palpable? No, the MR says, cool down. This is not a malignant picture. Well, we have already seen MR underdiagnosed things. Non-mass enhancement. Palpable. Blood supply. Yeah, but she's 25. I refuse, still refuse. We are going to drive it all the way to surgery. Now, young or not, you have to do wide localization. And then it comes back to you. And I start to think about that. Yes, it could be a black star. Partly because it's so big, the radiating structure. Well, still a speculation, isn't it? And here it is. Dear colleagues, I'm going to settle over to my microscope, and I invite you. Dear colleagues, here is the specimen. Should we look at the core biopsy? We could. Drive with me all the way. What is this? Fat cell. What is this? Totally normal acini. Look at this. There is a little snout. They produce the fluid. Now we cruise and we look for cancer. I cruise slowly. Very nice. Fibrosis, fat, acini, fat. I see no carcinoma. And then the pathologist says the same thing. I'm kind of reading the pathologist's report. There is a little papillary lesion. Doesn't make a difference. Can be a little bit of hyperplasia here. Several layers, no problem. Still, no cancer whatsoever. We just simply have to take it out, and we do. And here is the thing you saw on the radial scar, the specimen. Dear colleagues, this specimen I'm showing to you right here. So we are going to start down here. Anything that is red is fibrosis. Anything that is white, that's fat. This would be adenosis, and this would be a normal TDLU. More fingers, probably not adenosis yet, but do you understand? Many more acini, and the size is increasing. That's all. But of course you see nothing out of any of these, not the duct, not the TDLUs, because of this white stuff. So I see fat building block 1, I see fibrosis building block 2, I see terminal ductal lobule units, tons of them, and the little duct. Here we go. Should we call this adenosis? You could. Okay? You see, enlarged, proliferating TDLU, producing fluid. This is all normal. I hope I'm not driving fast. Just enjoy. Adenosis, normal TDLU. Really doesn't matter. All this is well within the boundaries of normal. Normal here, normal there. And now something starts here. Here is hyperplasia. You see the radiating structure, this one and that one and that one and that one. Here we are. This is the central portion of this radiating structure, all this. And then here it ends. So now we are going to go into it, and this is what is called hyperplasia. Not cancer, no. Elongated acini. This could be sclerosing adenosis. That is, the proliferating acini are not allowed to distend because the intralobular connective tissue, this one, proliferates and strangles it. Here we go. Looks like a broom. No, I don't see anything. And here is the central fibroelastic core, which is tiny. Tiny, tiny, tiny. Fibrosis, red, and hyperplasia. Isn't that a wonderful news for this young lady? 25-year-old? Absolutely. So then we leave this case. Here it is. That's a radial scar. Oh, look at this beautiful radiating structure. Just work with me and use your fantasy. You see, this one, and that 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 one. Great. This is how we get help. And here is what I showed you. Hyperplasia, a little bit of whirlpool here and there. Doesn't matter. No cancer. No atypia. No nothing. No sign of malignancy. You got a very modern, perfect workup of one case. I'd like to call your attention on this article, published by Italian colleagues. Actually, it was very interesting. They came to my course in Turin, and they went home, and they started a scientific trial. And they say we had 49 cases, single center, review literature, whatnot. They learned in my course, if possible, avoid 14-gauge core biopsy, rather surgery. So they actually did the core biopsy and did surgery in all of them. And in 9 cases, they had to change the preoperative diagnosis because it was associated with something on the step wedge. In 4 cases, it was actually frank cancer. If in 9 cases out of 49 core biopsy, you miss the important epithelial instability, also cancer included, then either we shouldn't do it, or we should say to the surgeon, I'm willing to do it, provided that you stick to the gentleman's agreement. You're going to operate anyway. But they don't. That's the problem. Case after case. She's 40. Hyperplastic breast changes are going to be diagnosed here somewhere 42, 55. However, the fibroadenoma is around 2022. Let's see what we got here. Here are the mediolateral oblique projections. Do you understand there was a very faint area here which needed to be detected? But it's on the Milky Way. You would have found it. Just don't fall in love with this encapsulated lipoma, because this is what is important here. So this is architectural distortion, certainly not a BCMO. She doesn't feel it. You don't feel it. Are these chubby fingers? Could be. Is this DAB? In a small breast like this, a DAB should have been palpable. I have the will and the ability of down-toning things. My cancer is always my absolutely last thought. So I do ultrasound. Yeah, Doppler is there. Did I get much help of ultrasound? Not really. If you say this is not a cancer, that's quite much of a help. Could these be ducts? Well, it would be difficult to convince everybody. And it's here, of course, and it's here. So you play around, and eventually, this is what you do. Now comes atypical hyperplasia. Whoops. Was there something in the left breast as well? Yes. And then you got a radial scar there as well. Now it's interesting. What did I tell you about the MR? Causes a bit of a headache, isn't it? You could really sign this out as suspicious for malignancy. Now we are in trouble. Well, actually not. Because we have the ups and the downs, and the ups and the downs, the MR says, yeah, the palpation says, nay, This has to go into the hands of the surgeon. I think they did a good job. And it's here. I'm going to show this to you also on the Huron, the microscope. Let's look at this one first. You see, this is where the meat is. This is the radiating structure. This is what is called fibroelastic core. We need a good pathologist who should be able to distinguish between hyperplasia only or associated cancer. But you see the enormous proliferation of the cells, whether it is with or without atypia or cancer, let the pathologist determine. Look at the power of this tool. It's about 20 gigabyte. Just this little picture is 20 gigabyte. Everywhere there is hyperplasia, and this one, it really catches my eyes. What a proliferation. Might have been shown up on the mammogram as a radiolucent part. And there are cystic cavities here. Proliferation. Here is a duct. And here is the proliferation of the cells and the tissue. Here is some apochromatoplasia producing this pool of fluid. Here we are. And here is another one. Now look at this cutie. This is an additional radial scar with a very large fibroelastic core. Hyperplastic breast changes are not only a headache for us, they're a headache for the pathologist as well. You see the difference between an entirely normal TDLU here and now what is this? Are they going to say that this is carcinoma, or are they just going to say that this is going to be a tremendous amount of hyperplasia? We are going to go back there, and then we are going to find out what the pathologist says. You see, I just showed you this tiny little thing, and now we are going to magnify both of them. Here is slight atypia. Now, slight atypia is an expression that shows that there is an enormous uncertainty. Eventually, there is no carcinoma here. And now comes the left segmentectomy. Similar story. You understand how well-trained pathologists are needed to be able to say that this is just hyperplasia. But mind you, you cannot take just a little piece from here and a little piece from there, because first of all, we radiologists would never learn. You have to see the whole thing here, the entire thing. What do you think this is? This is where the core biopsy was sliding, leaving scar behind. Proliferation, no atypia. Florid hyperplasia. Relax, don't scare the patient.